Good evening, everyone. We're going to be taking a look this evening at counseling children and adolescents with disabilities. We'll discuss the implications as well as interventions that might be involved. So, the learning objectives for the night, hopefully by the end of this video lecture, you will understand and be able to identify some of the counseling challenges that's working with children and adolescents that have disabilities. You'll understand some of the ethical implications, such as understanding what assent is, how we utilize confidentiality as well as autonomy when we're working with children and adolescents. And then also you'll hopefully be able to describe these type of interventions and how to use them with the children. And also talk about technology. Today, more than ever, we have AI and those type of uses, and because of that, there's what we have as assisted um, type of techniques. And just to give you a heads up, I'm including a 58-minute video lecture on assistive therapies and techniques for you to watch. So this particular video lecture will be a little long, but necessary. So with that in mind, more than likely, I don't know if when I go to create the video format of this lecture, if that video will pick up. And if it doesn't, that's okay. I will include it on Moodle so that you'll still be able to stop this video lecture and watch it. We'll make sure that you have it. With that being said, thanks for listening, and I hope this is going to be useful and helpful to you.
The prevalence of disability among children and adolescents is significant. The chapter frames that disabilities, broadly conceived, intellectual, developmental, physical, sensory, chronic health, impose not just functional limitations, but also psychosocial stressors, for example, stigma, isolation, as well as accessibility issues. Traditional counseling models often assume a typical client, but many of our approaches must be adapted, pace, format, modality, to be accessible, effective, and ethically sound for this population. This is also a justice equity issue. Children with disabilities are often underserved or poorly accommodated in school and clinical settings. So take a moment to think about this. If you were counseling a 12-year-old with cerebral palsy who uses a wheelchair and sometimes has speech difficulties, what are some immediate questions or adaptations you would consider? Consider therapeutic style, session logistics, power dynamics. How would that work for this population? So let's discuss the conceptual and ethical considerations. First, there's autonomy, competence, and assent. Even when intellectual or communication limitations exist, children with disabilities deserve to be involved in decisions to the extent possible. We often need to differentiate consent by guardian versus assent by the youth. Clinicians must assess decision-making capacity carefully and tailor explanations using visual aids, simpler language, or augmentative communication systems. Avoid infantilizing or over-controlling. Respect the client's voice. We must also know about confidentiality and privacy. When guardians, teachers, or caregivers are more involved due to accommodations, transport, care needs, the clinician must balance privacy with safety/coordination. Clarify to all parties, client, caregivers, what will be shared, in what form, and why. Then there are the systemic and contextual factors. Many children with disabilities exist within complex systems: schools, medical, therapists, caregivers. Therapy cannot ignore these. Structural barriers such as inaccessible buildings, lack of transportation, and scheduling constraints often limit consistent access to services. Also, we must look at the potential risks of over-pathologizing. There's a subtle danger of attributing all challenges to the disability, like diagnostic overshadowing. For instance, emotional distress or trauma should not be dismissed as just part of the disability. Additionally, clinician vigilance is needed to disentangle co-occurring disorders or emotional needs from disability-related manifestations. Now we have assessment and case conceptualization adjustments to consider. Standard assessment tools may not be validly applied to children with sensory, motor, or intellectual impairments. Adaptations, such as alternate response modes in simplified formats, or specialized instruments may be needed. Functional behavioral assessment is often critical for understanding environmental contingencies, communication demands, triggers, and maintenance factors. A strength-based orientation is vital. What can the child do? What supports are already in place? Here is a mini case to conceptualize probable ways to use. Maria is a 10-year-old with moderate hearing impairment, uses cochlear implants and mild learning disabilities. She's been referred for chronic anxiety, particularly social anxiety at school. What assessment adaptations would you make, like interview format, use of interpreter/sign support, visual aids? How might her disability shape your case conceptualization of her anxiety? For example, peer isolation, communication strain, identity concerns. Possible outcomes: use of visual graphic aids, written cues, or sign language support in assessment. Awareness that her social anxiety might arise partly from past failed peer interactions due to hearing barrier rather than just internal pathology. Consider her auditory fatigue or listening challenges as additional stressors. So let's look at some examples of adaptation covering domains and also common challenges. Let's start with the domain of modality and format. Traditional talk therapy may strain verbal, cognitive, or motor capacities. We use multimodal methods such as visual supports, art, play, movement, augmentative communication, shorter sessions, and interleaving breaks. Secondly, there's cognitive behavioral or behavioral therapy. Here are some of the challenges that involve abstractness, attention, and memory demands. So intervention should include simplifying tasks, scaffold skills, break tasks into small steps, more behavioral rehearsal, and/or use prompts or cues. The third domain is family/caregiver involvement. Caregivers often bear substantial roles, which is challenging for adaptation. We must train caregivers as co-counselors, consult with educators, align on consistency across settings. Next are environmental/contextual interventions. Challenges involve physical, sensory, communication barriers. Ways to help our clients adapt to physical space would be using accessible rooms, coordinating with the school for accommodation, and implementing assistive tech, which you will learn more about shortly. Finally, there's the therapeutic relationship and engagement. Major challenge here would be resistance due to stigma, frustration, learned helplessness. You want to adapt by slow pacing, validation of frustration, emphasizing competence, scaffolding small successes, using client-preferred modes. Here are a few examples. CBT for youth with intellectual disabilities. Use pictorial thought records, simplified feeling faces charts, role play, and behavioral experiments at home with scaffolding. For clients with motor impairments, e.g. cerebral palsy, the session may involve adaptive tech, speech output devices, allow nonverbal communication, and provide extra time. For autism/social communication challenges, integrate social stories, visual schedules, structured interaction games, video modeling. Imagine Eli, a 14-year-old with cerebral palsy, uses in the evidence, effectiveness, and challenges. According to Fedewa and Prout, empirical research with disabled youth is limited. Many adaptations and interventions are more practice-based than trial-tested. Some evidence supports that behavioral and CBT adaptations can be effective for youth with comorbid disabilities such as anxiety and depression. They caution about overgeneralizing from typical youth research and stress the need for rigorous outcome studies in disability populations. Here's something to think about. What kinds of methodological challenges arise when trying to run randomized controlled trials with children who have diverse disabilities? How might you design a more inclusive research protocol? Therefore, expect responses about heterogeneity, measurement validity, consent-assent issues, recruitment difficulties, attrition, need for individualization, and the tension between standardization and flexibility.
So now you're going to take a look into emerging technology and how we utilize that when we are working with our clients. The next slide is a video that will take approximately an hour, in which it's a webinar talking about assistive technology in terms of interventions. So just wanted to give it a quick introduction. If it does not work inside the video lecture here, I will also provide a link in Moodle so that you can go and view it there. Enjoy. All right, so now that you've had a chance to watch the webinar on assistive technology, think about, and hopefully we'll be able to talk about this next week, what adjustments would you make in terms of counseling to kind of ensure that the engagement as well as autonomy using this tool will be for your clients? How can you ensure that it's working? How can you improve on it if need be? Something I want you to think about.
To close, here are some final things to consider. Remember to start with access. Ensure physical, communicative, and scheduling accommodations such as room accessibility, extra time, and alternate communication. Check assumptions. Avoid attributing everything to the disability. Remain open to emotional, developmental needs. Use multimodal, scaffolded methods, visuals, play, role play, technology, in small steps. Engage systems, caregivers, schools, therapists, medical teams. Coordinate for consistency. Build empowerment. Focus on the client's strengths. Involve them in decisions. Calibrate pacing to their capacity. Monitor progress flexibly. Use multiple methods: qualitative, behavioral, self-report adapted, caregiver/teacher input. Advocate structurally. Therapists may need to push for service equity, funding, and accessibility in school or community settings.